The idea that we can now use a minimally invasive technique to accurately stage the axilla was one of the greatest things in breast cancer surgery over the last 20 years. However, we're now advancing that and starting to say, how can we now use it in areas where we hadn't used it before? So using it before neoadjuvant chemotherapy had always been something that we had felt relatively comfortable with. Because we know that we can accurately identify the sentinel node. We know that the false negative rate in that setting is very low. But now that a lot of patients are having neoadjuvant chemotherapy and a significant proportion are getting a pathologic complete response, the question is, can we do the sentinel node biopsy after? So the people who are proponents of doing the sentinel node biopsy neoadjuvant chemotherapy say, I can more accurately identify the sentinel node, and so I have a higher identification rate. I have a lower false negative rate because this is essentially not having chemotherapy interfere with that false negative rate. And so I can very accurately stage the axilla before chemotherapy ever touches the patient. So I have a very clear idea of whether the nodes are positive or negative at the outset. And for some other disciplines, for example, radiation therapy, which may be needed in the post-mastectomy setting, that's important. The people who are proponents of doing sentinel node biopsy post-neoadjuvant chemotherapy will say, you know what, the identification rate, now that we have gotten more experience with sentinel nodes, is still pretty good even after neoadjuvant chemotherapy. And while initially the false negative rates were as high as 33%, some very large studies now have found that the false negative rate is in the 11 to 13% ballpark, which for some is acceptable. And further, if we can find a sentinel node post-neoadjuvant chemotherapy that is negative, we can potentially spare those patients an axillary node dissection and all of the morbidity associated with that. And furthermore, if we didn't take out the sentinel node at the beginning, then we can more accurately stage that patient after neoadjuvant chemotherapy. So there is now a move towards doing that post.